Hello, everyone. Hello. We're going to be starting in about 10 minutes. We're going to be starting in a few minutes. Make sure that you go and take a bathroom break before the sessions begin. We will be in here for 2 sessions. We also have a little bit of an announcement for you. The Wi-Fi is currently down, so if you need to respond to any emails or take any, go to the website or anything, you'll need to use your personal devices. The Little America team is working on restoring it, but for the time being, the Wi-Fi is currently down. It shouldn't affect anything that we see up here or the stream. There's a hardwire internet that's working. So we're going to start in 5 minutes. Okay, we're actually going to start in 5 minutes. So you have 5 minutes to go and walk around, stretch your legs, clear off your plates. We'll be starting in 5 minutes. Yes? Okay, these are my last announcements before we begin. I just wanted to give a brief overview of what to expect on day 2. Thank you all for being here. Day 1 was a great success. Thank you for your engagement, your participation. Really appreciated all of the comments and ideas and thoughts that were shared. We're going to have more breakout sessions like we did yesterday. We're going to have people sharing their success. We want you to participate. We want you to comment. We have about 2 minutes before we're actually going to begin. I just wanted to clarify one thing. So we have a tabletop session this afternoon. They're called definition sessions. Hello, hello, announcements. We have most people are listening. There are some people that are still talking, which is great. So definition sessions this afternoon. We just wanted to clarify with everyone. We've heard a couple of comments that you're expecting us to present here. We're actually not presenting about governance or super users or informatics. We are seeking your input. So we're going to be publishing a white paper. We're trying to provide some clarity to the industry around these terms. When we talk about informatics, people ask us questions. Are these clinicians who are board certified in informatics? Are they IT professionals who are like a liaison between IT and clinicians? Or is it something different? So we're trying to provide some clarity. So on the back of your name tags, you'll see a table assignment. Please go to that room. We're going to be having a discussion in each of these ballrooms, hopefully trying to clarify and publish something that we can agree on. These are industry recognized terms. So 2:45 to 3:45, please come prepared to engage and to talk and to participate in these tabletop discussions. We are going to begin now with our session, and so I'm going to turn the microphone over to Bob Cash to introduce our keynote speaker.
I'll add my good morning. Good to have you all here again. Great to see you all. Interesting story this morning before I introduce Dr. James. I woke up. This is a thank you to all of you that might take me a minute to share. I woke up and thought, I just did not sleep that great in this bed. I don't know if any of others of you felt that way, but it's not my home bed, right? And so the song came into my head, One More Night. You know that song by Phil Collins? It's like, one more night, I can handle it. And so I decided to go for a walk. I went outside. As I came off the elevator, guess what song was playing? Literally the words, one more night, as I came out of the elevator. So I took my walk. I came back and thought, I wonder what the song's going to be when I come in here. So it was Silly Love Songs by Paul McCartney. So I love you guys, really. And we are so appreciative of your being here, really, and sacrificing one more night with us so that you can learn together. We have 80 faculty out of 350 people here who have contributed to sharing their experiences with each of you. But I know there's a lot more sharing going on than that. You're talking at the tables. You're sharing your experiences, your challenges. That's all part of what we're trying to accomplish here in this collaborative. So thank you for your willingness to do that. Okay, now it's my privilege to introduce Dr. Brent James. Last year at this conference, if you were here, I made some introductory comments, and among them was this slide. And I'm not going to go over the slide. It's just to remind you that we actually talked about and quoted Dr. Brent James last year. And following that summit, I had some people say he would be a great person to come speak to this conference. And Dr. Brian Bushik, who works with Amplifier, actually called me, I can't remember, January-ish or something, and said, I know Brent. And I said, well, I know Brent. And so anyway, together we decided that we should really invite Dr. James. And so it was a privilege to be able to talk to him, and I'm honored that he'd be willing to be one of those 80 people who are willing to contribute to this summit. Dr. James is known for his work in clinical quality improvement, patient safety, and the infrastructure that underlies successful improvement efforts. And that's part of what made me think last year. And we talked about the fact that this really is a process improvement effort that we're all involved in. And class gets to be a part of the measurement part of that process, and so hopefully a lot of other things beyond that. But you're doing a lot of the quality improvement efforts in your own facilities. Dr. James is formerly Chief Quality Officer and Executive Director, Institute for Healthcare Delivery Research at Intermountain. And through his advanced training program, ATP, he has trained over 5,000 senior physicians, nursing administrative executives, nursing and administrative executives drawn from around the world. I am proud to be one of those. Went through his course many years ago when I was working at Intermountain Healthcare. One other just quick last story. I have with class had the opportunity to travel a little bit. outside of the United States. And again, when people find out that I at one time worked at Intermountain Healthcare, they say, "Oh, do you know Dr. Brent James?" I'm like, "Well, yeah, I've met Dr. James." So his reputation is very large. But with that, we were just talking about the fact that he grew up as a farm boy, a ranch boy in Idaho. I grew up in Idaho as well. And part of my story last year was about my grandpa, who was a rodeo cowboy in Idaho. So it all comes back to small and simple things. So again, it's my privilege and honor to welcome Dr. Brent James.
Thank you. It's interesting, Bob, because I was closer to the whole rodeo thing. My dad roped calves, steer roped, and holy cow, I spent a lot of time at rodeos up in southeastern Idaho as a young man. It's a delight to be with you today. I have to tell you, in getting ready for this is one of the harder talks I've had to prepare in a long time. Actually took a fair bit of work. We'll see how it goes. I hope it's at least entertaining, maybe informative. Some key ideas along the way. Before I get into it, though, I better reveal a couple of things. Number one, in the time I was at Intermountain working on clinical quality improvement, it became clear that IT was one of the critical infrastructure pieces for doing clinical decision support, rather obviously. In fact, I'm going to argue to you that if you're not using your IT investment primarily for clinical decision support, you're missing at least 50% of your ROI. That's where the real benefit comes, dramatically in spades. Unfortunately, that term does not well describe the current vended products in the United States. They weren't designed for that purpose. Well, at Intermountain, across 15 years, I led a team that was designing a next-gen EMR. It's designed to run on top of an Epic or a Cerner or a Meditech. You need to know, just full disclosure, it's called Sevilla Health. They stood it up as a separate, and I serve on their board. All right? So I am deeply biased, just to warn you. We probably won't get into that today, though, unless you lead us into it with questions. I also serve on the Clinical Innovations Advisory Board for Amplifier. It's a fun thing when Bob Bergen, who heads that company, came and presented to us. We ran an experiment around patient safety, and holy cow, did it work, to the point where I decided to help out. So I'm biased about that, too. Probably won't talk about that anymore either, to speak of, at least not directly, but you need to know about those things. Well, I hope to do three things in the next 45 minutes. Number one, what Bob Cash actually asked me to do was describe how quality improvement would apply to something like the Arch Collaborative, which is kind of an interesting twist, to say the least. That's going to turn into something called, well, Maureen Bisignano at IHI, based on work we did here in Utah, actually. She had a really clever way of saying it. She called all teach, all learn. And if I were thinking of the Arch Collaborative, that's probably the term I would apply. The reason you come together is to learn from one another. All teach, all learn. And I'd like to make that argument a little bit. Then I'm going to shift into the stuff I really, really like. I'd like to talk about clinical decision support a little bit and how it ties into IT, where I think the real opportunities lie. Fair enough? Well, to kick it off, this guy's named Ed Deming. I'm probably one of the last people alive who actually learned at the feet of Dr. Edwards Deming. In fact, in 1989, he helped me publish the first major paper on clinical applications of quality improvement. That was a long time ago. Some of you weren't born then, probably. End of his career, the start of mine in healthcare. Quality improvement, though, is really the science of process management. Deming argued that you could describe any productive human activity at all, anything. Selling clothes at Nordstrom's, changing the oil in your car, preparing your taxes. Caring for a patient with newly diagnosed pancreatic cancer. You can describe it as a process. It's a very simple concept. A process is just a series of linked steps, often sequential, but not necessarily, that creates a product or service, generates data or knowledge, causes some set of desired outcomes to occur, in some other way creates value. And Deming was correct. Processes can be used to describe any productive human activity whatsoever. In theory, even a meeting of the Arch Collaborative could be described at a process level. This is where it really takes its power, this idea of process. And I wanted to talk to you about that just a bit. Deming's idea of process. Yeah, again, quality improvement is the science of process management. In healthcare, we sometimes call it care delivery science. It's how you execute, how you actually get things done. Well, it comes in many flavors. I just tossed this together off the top of my head. I know of 10 or 12 across my career. What each of these were yet another consulting group trying to sell the idea to administration in an organization, your organizations, all right? Interestingly, they're all pretty much identical. At the core, it's all Deming's process management science. Oh, they changed the jargon. When you're trying to resell the same thing to the same people, it's helpful if you change the name and change the jargon. Motorola Quality with Bob Galvin, wonderful success stories, total quality management, reengineering, GM Picos, the Alcoa version of Lean, which was the first one to roll out, lasted about 5 years. The Malcolm Baldrige Quality Award helped build that one. It's all about process management, by the way. Six Sigma GE style Lean from the Lean Enterprise Institute. That's the current version. Some people combine them together. I've left off several. You get the idea? At the core, though, they're all the same thing. A couple of new tools, nearly always, that you strip out and dump in your toolbox. But at the core, 90% of it, literally, is Ed Deming's process management science. All right? One of my jobs at Intermountain is every time an administrator went off to some conference and got some new bling they dragged home, wanted to spend $5 million on, the new current version, would be to strip out anything new, dump it into our constancy of purpose, and keep moving ahead on the same track. Tools, methods to design, deploy, manage, and improve processes. Now, I'm going to use one today called rapid cycle improvement. It's not on my other list. It should be. It's really documented in a book called The Improvement Guide by Langley and Nolan, all right? The reason I like it is its layout is almost identical to what we learn as clinicians, physicians, nurses, pharmacists, therapists, technicians in our training. It's a research model. The same thing we learn in a research model in rapid cycle. It means when you're talking to a room full of clinicians, many of us do that. I bet even some of you do that. It means that you match up to the way that they see the world, hear the world, structure the world along the way. So I'm going to use a rapid cycle approach. We'll get to that toward the end, I suspect. Now, the key thing, though, and I wanted to show you an example of it, it's all about variation. You're executing a process. Many of the processes we use in healthcare have never been formally defined. And one of the key concepts, well, I'm going to label it this way, unwarranted clinical variation. And you can structure the opportunity in terms of that quite nicely along the way. I don't plan to dive into it heavily, but I want to show you one example and a lesson learned. Back when I was working with Dr. Deming, this would have been 1986, 87, 88, a long time ago, we were doing a series of studies. People like Jack Wenberg at Dartmouth had studied geographic variation. And we'd asked the question, I wonder if that kind of variation exists inside a single facility, inside a single hospital. We call them quality utilization efficiency studies. We studied 6 areas. They're on the slide. You don't need to know them for what we need to talk about. Let's just say, to my knowledge, it was the most rigorous approach ever done of this fundamentally observational design. You can't do a trial around this. So it's inherently observational, but you did the work so that basically you had a group of patients that were identical coming in, identical going out, and then it was fair to take a look at what happened in the middle. Well, the thing I want you to know, we found massive variation. These are 2 factors in a surgical procedure called transurethral prostatectomy. 16 high-volume surgeons. These are identical patients, best we could tell. The little green squares are true surgical cut time. The little red circles, the purpose of the procedure, grams of prostatic tissue removed. See the amount of variation, though, in that slide? It directly linked to clinical outcomes. So what you're seeing is massive variation. This is if you looked at the cost data at the time. Cost of care showed similar variation, about a twofold difference from M, the low, down here at $1,164 to H, the high up here at the top, $2,233. We studied 6 major areas, twofold differences in cost on identical patients with identical outcomes. But here's the thing I wanted you to see. This is actually a summary slide. We were running activity-based costing, so we had very accurate cost data in this setting. This is about 45 cost factors rolled together. In total, if you throw in the clinical, it was about 90 factors. Well, break them out. Don't look at the summary, look at the details, and you'll make the most interesting discovery. When we examined the detailed data, there was no single instance where one surgeon was consistently good or consistently bad, consistently high or consistently low. That's interesting. It became apparent that if you were looking for best care, best performance, best execution, it was scattered across the group. You couldn't find it by asking any one person. All right? I said earlier, Marlene Bisignano, seeing this, said, oh, I'll teach, I'll learn. Fair enough. Yeah. I think I've just described the Arch Collaborative. Isn't that the purpose that brings you together? I'll teach, I'll learn. What I know is that every person in this room has something you can teach. I also know that every person in this room has something that you can learn. And so when we think about applying quality improvement, process management to the Arch Collaborative, the question becomes, how do we pull forward those learnings so that all members of the group can benefit from them? Fair enough? It's a really common theme that you see all the time when you're doing improvement. An example, I want you to get now to the process level. This was back in the early 2000s. I had 2 friends at Dartmouth. Steve Plume ran the Dartmouth physician group. It just happened he was a thoracic surgeon. He was in Bill Nugent's department of thoracic surgery. They'd put together something called the Northern New England Collaborative. 5 big academic centers up in the New England area. All of them did bypass graft surgery, and they were learning together as a group. One day, Nugent gave me a call. He said, you know, Steve and I want to come out. We know that you run a really good open heart program. Can we come learn from you? He said, we just want to observe and learn. And I quite magnanimously said, well, sure. Come on out. Picked him up at the airport. What they did is they spent time with our teams. They scrubbed into surgery, the actual surgical process. They spent time sitting with the pump techs as the surgery took place. They spent time rounding, caring for patients in our thoracic ICU. They got in at a process level. And before I knew it, I started to get reports back from my frontline teams who were doing this, my friends who took care of those patients. Holy cow, they were learning a lot. What they had were 2 true process experts, Plume and Nugent, watching what they were doing and commenting on it. You can't put that in a paper. You can't describe it well enough. You can't do it on a Zoom call. It only ever happens where the rubber meets the road. It's funny, when I was driving them back out to the airport at the end of their visit, even by that point, they were being very complimentary of how much they'd learned. What I knew is that for everything they got, we got 10. All right? And that was the honest truth. The key was, the thing I want you to remember, I had 2 process experts engaged at a process level. That's where the learning took place. You see that idea? And it was a big deal. It really helped us out. Returned the favor, sent a team from here out to them, and frankly, it was worth the money, the time away from real work and the airfare and the hotels and the like. What I know talking to them is that we gained, they got more. Do you see that idea? Again, to focus back on process level, I had another example I wanted to share with you. I helped organize with the folks from Dartmouth and Mayo Clinic something called the High Value Healthcare Collaborative. At one point, we had about 30% of all care delivery in the United States came through hospitals that were part of the HVHC. I was chairing their board. at the time. We were capturing data from those facilities, not just a core UBO2 record, a standard case mix record, but around specific conditions, we had extended clinical data as well. And studying it together, we decided to put together a collaborative on total knee arthroplasty. My guy who was a really good orthopedic surgeon from St. George, Utah. Dartmouth stole him from me to be head of the Department of Orthopedic Surgery at Dartmouth, the Turkeys. Dave Jesvar. But I knew he was going to go meet with the other surgeons. And I said, Dave, I said, let's do something to get ready. He and I sat down together and we made a relatively simple process map. We built it at the level of patient flow, or what happened as a patient went through the process. We knew it wouldn't be correct. But I said, let's get it on paper. Let's make it explicit so we can criticize it, change it. Turns out you can't think about a problem without having that in the back of your head. It's always there. It's just usually subconscious. Well, we made it explicit. I said, what I'd like you to do is when you get to that meeting, just hand it out. And sure enough, once again, as it happens so often for us internally, the surgeons from those other places looked at it, and then the debate started. Turns out we all use different processes. What had we done? We'd made the difference in process explicit and observable. And that's where the leverage came. For example, we discovered that Mayo had completely front-loaded the process. They didn't have post-acute care. I presume it was because so many of their patients travel in from a distance, but they front-loaded all physical therapy. No post-op physical therapy. It worked. They'd done it in a way that really worked. Wow, there were some cool things in that. New ideas for us. Intermountain, we'd standardized the inter-op process. Much shorter operative times, much fewer inter-op complications, but it was explicit. We could share that. The Dartmouth crowd, they were doing a great job around patient selection, patient participation, what they call co-production of care, as Paul Batalans worked it up. The key was making it explicit. Now, Bob, I'm not quite sure how you do that in the Arch Collaborative. You'd have to take specific topics, but that idea of making explicit process turns out to be very, very powerful, just as a framing idea of how you might approach it. At the core, it's all about process. At the core, it's all about all teach, all learn. Back to the theory. Now, many people make a mistake when they talk about quality improvement. There's a sub-element of it that we call database problem solving, all right? Where you use data to structure a problem, then you use data to test hypotheses about change to improve it. It's called PDSA cycles, plan, do, study, act cycles. You've all hit it. The sad thing is so many people think that that is quality improvement. It's a mere fraction of the whole theory. It's a key fraction, and dang, it does work. Oh, if you can do that and do that well, I'll give you a green belt level in quality improvement. But I think for Arch Collaborative, you may need to come closer to a black belt level. We don't have time to really get into that, but here are some of the things that Deming listed as part of it. He called it profound knowledge. Number one, appreciation for a system, or you think of things as systems. Fundamentally, that's taking processes, combining them together, and build systems. A system is a combination of underlying processes. It's a fractal concept. Number two, a theory of knowledge. How do you learn from your own experience going forward? A formal theory about how you learn, then feed those data back and apply them in your own work. So leading directly to change. Knowledge about variation. We've just been talking about that a bit. I used it to highlight all teach, all learn. But variation is a very strong approach to use. How do you differ from others? What Plume and Nugent taught us when they came and watched our processes. That very simple, boots on the ground approach to process management, you see? Or when Jevsvar shared an explicit process map with colleagues from around the country on how do I do a total knee. You see the idea. And lastly, you have to understand the psychology of change. This would be on how you lead clinical change, which I actually think might be a really good topic for you, I suspect. We know a fair bit about that today. especially with clinical change. I have a funny thing for you, though. 2005, a fellow named David Foster Wallace, an American novelist, gave a commencement talk at Kenyon College, and some in attendance, particularly a Time magazine reporter, said that it was the greatest commencement speech ever given. He was apparently pretty impressed. Started with a cartoon. The cartoon shows two little fish swimming toward what turns out to be an old elderly fish. And they pass each other as they swim through the water. Here they are passing. Here's the young fish. Here's the old fish. The old fish says, "Hey, boys, how's the water today?" And the little fish say, "Great, it's fine." Then they swim on past. You see the one little fish looking back at the old guy. Then after they're all past the old guy, one of the little fish says to the other, "What's water?" Actually, in an IT department, this describes you. All right? In a particular way. You create the system. Your main job is to create the system within which physicians, nurses, pharmacists, therapists, technicians execute the main operations that justify your existence as an organization, caring for people with health problems. Fair enough? You create the water. Many of the people who work within it don't even realize they're swimming in water, but you have to, because that's your job, quite explicitly. I will leave it mostly to the handouts. This is Ed Deming talking about systems. People work within the system, but management creates a system. And I think in healthcare, to a degree that we don't see in other industries, that information environment is just absolutely essential. I've had some real successes in this, and essentially all of them came from manipulating the information to make it really easy for my colleagues to do it right. My favorite was when they didn't even realize it was happening, and they still got better. All right? Deming used to say that 85% of reasons for failures or deficiencies in any organization come from systems. I think it's closer to 95. That's why I stuck 95 in brackets after it here. All right? Any substantial improvement must come from action on the system and is the responsibility of management, your responsibility. A bad system will beat a good person every time. True thing was never said. Put a good person in a bad system, the bad system wins. No contest. What kind of systems are you building? Frankly, in most places where I visit and look at the IT infrastructure relative to delivering care to patients, it stinks, if I'm honest about it. And it's yours. The problem is a vision about why you're there, what you're trying to do. If I could give you that vision to walk away in terms of how you fit in this critical enterprise, I like to say that we count our successes in lives, and a truer thing was never said. I could document more than 2,000 fewer deaths per year in the Intermountain system as we applied these ideas. People who in the past would have died who didn't today. It's associated with massive financial performance. Finance department set across 4 years, tracking just 5 big processes, not nearly our whole scope of work, $700 million out of Intermountain's cost of operations across 4 years, all right? Dramatically better clinical outcomes, dramatically lower costs, and what it depended upon was the water, the systems within which you function. So Bob, if I were to add another element to class, that's why you're here, it seems to me. To learn from one another, to understand how you can create those sorts of systems that make a fundamental difference in how we execute healthcare delivery. Sound big enough? You realize what you've tackled? We literally count our successes in lives, and you're the folks who play an absolutely central role in those systems, all right? Now, I can think of 2 ways to really improve IT. One is to make clinical users more expert or facile with your existing tools. course, what I'm hinting at is you really need to improve those tools in a significant way with a clear vision of purpose. I wanted to show you those very quickly if I can, just for a few minutes. One example, without naming any names, how to use tools, EPIC training. I really like the idea of replacing the classroom. They just did it to me again. I whine about it endlessly. Stanford, California, it turns out those losers passed a law that I have to get 2 hours of training on sexual harassment every year. The poor folks at Stanford who then try to meet that state mandate, they've done a relatively good job. You could contain the whole content literally in 10 to 15 minutes. But they killed 2 hours of my time, and I resented every minute of it. Oh, I'm sounding like a physician. Well, actually, I'm also sounding like any nurse. And most administrators, you guys get it too, don't you? You have to go through that compliance training, don't you? Do you just love it? Just look forward to it? Just say, wow, I learned a lot. Yeah. Turns out that we have methods these days based upon new science around how the human brain learns. When we applied them inside Intermountain, we showed dramatic improvements in outcomes. I won't go into details, save it for later. It was mostly around patient safety topics like central line bloodstream infection, catheter-associated urinary tract infection. We cut our nurse training time by over half. That was a significant savings. The real money in that was those people away from productive work. Just take their salaries and figure out how much you're spending. For one of our high-functioning ICU nurses, we reduced it from a couple of hours to 7 minutes, literally, with a reliable tool so we knew they had mastered it. It was associated with over a third drop in major complication rates. See the idea? Well, expertise increases, cost of training decreases, a big one. Our clinicians loved it. It was respectful as opposed to demeaning. How do you run your training? I'm sure you're doing it. How could you run a training program around using IT that worked more effectively? That's the question I really wanted to ask with this. A real fun one. I want to share a case study with you on the clinical side. It's got a quiz at the end, so I'm going to run a quiz with you. Fair enough? So here comes the quiz. Background. We had about 60,000 type 2 diabetics in the system. About 90% of all care was delivered by primary care, not specialists. In fact, we only had 6 endocrinologists for 60,000 type 2 diabetics. That's a real difference from most places, just in passing. Very fragmented system. Over half of all the physicians we were working with on this particular topic were not employed by our system. By the way, if you believe that employing a physician will make any difference around these issues, you need to rethink it. Doesn't. It was a big group of physicians involved, all right? But what I wanted you to see, first of all, we really improved the care. I'll skip past them fast. This is a blood sugar control, dramatically improved. This was a clinical trial for the complex diabetic patients. Diabetes mellitus, at least 3 significant comorbid diseases at 2 years. We showed a significant improvement in survival rates. We showed a real reduction in hospitalization rates, almost 25% reduction, relative reduction in hospitalization rates. I won't go through it in detail in the interest of time, but we showed dramatic improvements in every measure of diabetes control. In fact, we were achieving outcomes that would go head-to-head with any specialty group, but where essentially all of the care was delivered by primary care, all right? That's what we showed. I want to show you the IT tools we use to do that. What I'm doing is creating the water, creating the environment within which my clinicians operate. All right, is what we're doing. There were 4 of them. Now here's the trick. I'm going to show you the 4 fairly quickly. Then I'm going to ask you in your experience to raise your hand. Oh, we did it with what's called a factorial design. That means I could measure the independent contribution of each tool accurately. So I know what worked. But the quiz is going to be, I'm going to ask you what you think caused this to work. I've shown you this dramatic change in outcome. That's what it produced. It worked. Fair enough? Action lists. We maintained a registry of all type 2 diabetics. This is a real one. I've stripped off the patient information, of course, HIPAA. What it did, we'd produce it quarterly. Most places would get it out monthly. Usually it was a nurse who went through it, sometimes a primary care physician. Just listed every diabetic patient coming down the list. The little green bars so you could make change to your registry content. This is not my patient, this patient's moved, this patient died, whatever, right? To keep the registry relatively clean. It didn't have to be perfect. It's about 95% accurate, and that was more than enough to function well and be appreciated and used well. What it did was flag any patient who was not in perfect management. Needed testing, their blood sugar controls weren't appropriate. I mean, they needed better sugar controls, whatever. See the idea? They'd typically do it monthly. It means that the care became continuous. You didn't have to wait for a patient to come in for a visit. You could track them even if they didn't show up, and you'd know who to call and bring in for a visit. If you see the idea, that's an action list. So you got that one? Number 2, we call the patient worksheet. This is a fake one. Just to show you the layout, when the patient came in, we worked it into workflow, into process, so that when the physician went in to see the patient, either this was pulled up on the computer, if it was fully electronic. A lot of them were paper-based systems still. A lot of the physicians weren't on our IT backplane. It'd be paper clipped to the front of the chart. Patient name and demographics up here at the top. It had a list of their chronic conditions. That's what drove the logic in the IT system. So you had an encoded type 2 diabetes mellitus code that would fire the logic, you see. Full medication profile, obviously fake. This one only lists 2. Real patient like this would have 10 or 15. Preventive care summary for screening, you know, for immunizations, those sorts of things. Labs pertinent to their chronic conditions. Exams pertinent to their chronic conditions. We called them passive reminders. They were really orders. We knew what needed to be happen from the care process model, from the algorithm, from the guideline. We call them passive reminders because they don't always fit. And the physicians were worried about legal perjuration. So everybody used them as orders. On the electronic system, you could just check or uncheck them as orders, and this one you just paper check them off. Wow, those were popular. Really liked them across the system. Number 3, comparative outcomes. Dr. Towner lets me use this with his permission. Mayo-trained internist, general internist. He has about, 244, it says right there. Type 2 diabetics in his practice. That's big, guys, for a general internal medicine practice. What it shows is his testing rates right here. He was really good. 100% of his patients were current on blood pressure measures, for example. The little bar charts show level controls, and he did very well. That's why he lets me share it, I suspect, is because he looked really good. As you might expect, it's one page, it went to another page, but it shows exactly how you, the blue bar, compare to your region, the red bar, to the system as a whole. The green bar is your region, the red bar is the system as a whole. It just showed how you compared. So how do you compare? This is the version that went to your medical director. I jokingly say that it was worth a free lunch. If you were doing poorly on diabetes, your medical director was going to invite you to lunch. Okay? And then lastly, tool number 4, we tied it to financial incentives. It was a summary metric. Diabetes always played a major role within it. Relatively small, about plus or minus $3,000 per year swing. So $3,000 ahead, $3,000 behind. At the time, these guys, their average annual salary would have been about $150K. So not huge, but 1-2% of your salary in play. So now you've seen the change in outcomes. You've seen the 4 tools. Now you get to vote for exactly one item. Just one, not 2. And you shall vote. If you see somebody at your table that doesn't vote, I want you to help me keep an eye on them. And if they don't vote, I want you to call them out. So which of these tools was most effective in driving dramatic clinical change? How many of you think it was the action list? Raise those hands high so I can count them. 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18. How many of you think it was the patient worksheets? Too many to count. More, but not many more. How many of you think it was comparative outcomes? That's what always happens. Everybody thinks it's comparative outcomes. How many of you think it was financial incentives? Here's what you need to know, guys. 95% of the effect were the first two. This is a consistent finding, time after time after time. Why do you believe that comparative outcomes will change performance? Why? What is the mechanism by which that works? And if you voted for that, I want you to take the time to study it carefully. It's wrong. All right? And it's making you ineffective as a leader and as a system designer, as a person who builds the water. By the way, financial incentives had zero impact. We included it because it was fair. It was the only reason it was there. Zero impact. If you're not familiar with that one, you need to go read the best lay text on it. There's a whole literature around it. Dan Pink, the book's called Drive. And understand what happens in heuristic settings as opposed to algorithmic settings around financial incentives. In a care delivery setting, financial incentives, if you're relying on them primarily, actively damage performance. And there's a strong evidence base demonstrating exactly that. Well, why did I talk about this? You create the tools. One of the things I think you can really get in an Arch collaborative is the idea of which tools work and which tools work well. There's a level of rigor you can add. You know, I headed the Institute for Healthcare Delivery Research, and we were pretty rigorous about this stuff. We wanted to know what worked. The idea that you learn from each other. The idea that you learn not just what system changes will make you more effective around training, around the systems that you use to drive support. You also have the data to know empirically what works. The thing that still surprises me, we have a lot to learn as an industry about what works and how it works. The evidence is there. It's just not widely appreciated. To the extent that you master this, you will become dramatically more effective. And I will suggest that you as I will be able to look back across a career and say, I made a real difference in people's lives. I made a difference in the lives of the people who used the systems that I created. I made a difference in the lives of the people who came to the system of which I'm a part when their health was on the line, when they were facing suffering, death. All right? And you will know that you've left a legacy beyond compare, that you made a real difference in the lives of your fellow beings on the planet. Yeah, that's what I wanted to leave you with. Your real goal is to make it really easy to do it right. Your real goal is to build those systems along the way. Oh, I throw this in just because you need to see it. The real reason that I whine about the whole Stanford, California thing, it destroyed my productivity for that day. I admit, half of the productivity loss was because of my whining. I got so tangled up in the whining that, that doubled it, roughly. There you go. I'm a human being. What can I say? It turns out when you do this and do it well, nearly always it makes frontline care delivery easier. When you're good at it, clever at it, it makes it easier to deliver state-of-the-art care. And at that point, suddenly those clinicians become your primary partners, supporters, colleagues, co-creators along the way, because you share core goals. This is just to show the impact. We published this in JAMA. Given that we were talking about diabetes, the short version is to stand this up across a series of chronic conditions. It costs us, technically, we said in the paper, $22 per member per year. This is about 140,000 patients coming through a health plan, about 70% commercial, about 30% Medicare. About $18 per person per year to stand it up, about $3 million of investment. It always requires an investment. But our total medical expense fell by 115, about $19 million in savings for that $3 million investment, 5-to-1 ROI. Not bad. Mostly because of reduced hospitalization rates, reduced visits to outpatient procedures, reduced ED visits. See the idea? I want you to know it really works, not just for clinical outcomes, but for the financial performance of the system of which you're a part. So my main argument, your primary purpose is clinical decision support. When you do clinical decision support and you do it well, you start to get that. And frankly, there's nothing else you can do in a health system that has bigger financial impact on your performance, in all honest truth. Nothing even comes close. All right? And I'm talking to a room full of people that are at the center of it. You know, Nolan's rapid cycle improvement says you really have to ask 3 questions when you're going to do improvement. 3 questions I pose to you. What are we trying to accomplish? We've talked about that a bit. How will you know if a change is an improvement? That means data. Part of your responsibility too. What changes might we make that would result in improvement? Well, I thought I'd just leave you on that quality improvement note. It's a delight to speak to you. The reason is I honestly believe that no group in healthcare has a bigger opportunity to make care dramatically better than you do. At a fundamental level, you own the systems upon which good care delivery depends. Go forth and conquer. With that, I'll say thanks for your time and attention. Do we have time for questions? Holy cow. So this is where you get to say, Brent, you're just absolutely wrong, and here's why. But
We have time for a couple of questions.
are there questions that provoke any comments in your mind? Speak very loudly.
There's a
Here
mic
comes a
coming.
microphone. Who's number 2?
So thank you. That was just great and a lot of fun to listen to. Can you share your drivers of change with the federal government and the insurance companies? Because because they truly believe that financial incentives and comparative effective analyses are the driver of change, and they push us in that direction
Yeah.
all the time. And it kind of it's the water we swim in, right?
Yeah, so just 2 ideas in that regard. The first is, it started when Mike Leavitt was head of CMS. He was the former governor of Utah. I was working with him a bit. So back in the George Bush administration, they identified something called value-based care as the primary strategic focus of the CMS program moving forward, the largest health purchaser in the United States, in the world, frankly. The fascinating thing is after the Obama administration took over, they continued with that as their primary goal. When Trump came in, still their primary goal. Under Biden, I've got the slides, it's still their primary goal. The frustrating part is it's been moving more slowly than any of us would like. What I've just described to you is the core philosophy behind value-based care, just in passing. We'd have to add more detail. So the government's been actively pushing it for the last 20 years. The frustrating part is it is moving and it is growing and it's on a curve and it's gaining steam, but it's frustrating that it's taking so long. We could argue that they're not doing it as effectively as they should, right? But you know, that's a separate argument along the way. The second one, my favorite story around this, see that thing that happened with us around management of chronic disease in an outpatient setting? I have a friend, his name's Pat Conway. He runs the physician group at Optum, completely owned subsidiary by United Healthcare, the big for-profit insurer. When I talked to him a little while ago, his goal this year was to add 10,000 to 15,000 more primary care practices to his book. He's at about 60,000. Largest employer of physicians in the United States. That is his philosophy. That is his business strategy. Do any of you work for hospitals? Where's the money coming out, guys? His explicit strategy as an insurer is to work with primary care to drop hospitalization rates. Great strategy from a patient's perspective, by the way. And the people who are going to suffer under those blows are hospitals. Already starting to happen. All right? More and more systems are shifting into a value-based care setting. A bunch of it, some of the private equity money going into primary care. My favorite's ChenMed, Chris Chen, based out of Miami, Florida. Same strategy, and they're being massively successful along the way. So you get a choice. This is happening. And in communities where it is happening, hospitals are taking the hits and taking them hard. Are you going to lead? What is that old saying? Are you going to be at the table or on the table? That's the question for you, because it is happening. It's not necessarily nice. It can be moderately brutal, but there you go. And frankly, I'm going to say another thing that may be unpopular. Having watched so many health systems dabble their toes in this and then not commit, you deserve it. Speaking to the senior leadership of your systems, you deserve it in spades for screwing around when you should have been leading. Because if you don't lead, others will. And that's just the honest, true reality of what will happen. By the way, Don Berwick and I and a guy named Ross Wilson consult for the government of Singapore for health reform in Singapore, one of the better health systems in the world. We just picked up Saudi Arabia. They're moving to a government-run health system, which is really interesting. I do the same for Sweden, my favorite health system in all the world. This is true not just for the United States, it's true around the world is what I'm really trying to say. Same's true in Canada. The same basic philosophies, different settings, but the same underlying fundamental science, if you will. Same's true in Australia, spent a bit of time there, worked with other groups across Europe. A lot of my students in those systems, all right? So this, I'm gonna argue to you, this is the future. Change or die. So, what a great way to end. I think there's a mandate hiding in there somewhere is what I'm trying to say, but there you go. So thanks, Bob.
Hello. Hi, everyone. We technically don't have a transition period right now, so we're going to adjust our schedule by 5 minutes. Go ahead and take a 5-minute break. We'll start our panel in 5 minutes. After that, we do have a break. So 5-minute break right now. We're going to adjust things by 5 minutes. Okay, everyone, please go ahead and take your seats again. Go ahead and find your chairs. We're going to begin our panel here momentarily. Thank you, everyone. Please come in and find your seats again. We have learned from our mistake that we do need a transition between sessions. We thought that if we stayed in the same room, maybe we could get through it, but we were wrong. So this is our fault. But thank you. I know that was a quick transition. Please come in and find your seats. Okay. Thank you, everyone. Thank you. Really appreciate this. We're going to begin our panel now. We're going to be talking about burnout and turnover. I'm going to pass the time over to Kathy from our team, who's going to be moderating. Really excited for this panel. We know this is a hot topic. This is a problem that we are currently living through. It's a big problem, so excited to hear the insights that are shared today. Kathy, the time is yours.
Great. Thanks, Connor. Welcome, everyone. Like Connor said, we know this is a hot topic. Burnout, as we know, kind of peaked during COVID. And unfortunately, we have not seen that abate at this point. We're still